So this is a learning session on respiratory failure. People can go into respiratory failure at home or on the road due to worsening of a medical problem they have, or following a road traffic accident, or any patient who is admitted in a hospital already can go into respiratory failure in the medical ward or surgical ward or in the emergency department or anywhere else. So what is respiratory failure? Respiratory failure is a condition associated with inadequate gas exchange in the lungs, which is characterized by a severe hypoxia, and it is defined as a arterial partial pressure of oxygen, or PaO2, capital P, simple A, O2, less than 8 kilopascals or less than 60 millimeter mercury. Then, depending on the PaCO2, arterial partial pressure of carbon dioxide, respiratory failure is divided into two types: type 1 respiratory failure and type 2 respiratory failure. So respiratory failure is a common cause for admission to critical care unit or the intensive care unit. Now let's see what these two types are. Right, so first we will look at what type 1 respiratory failure means. So type 1 respiratory failure is characterized by a hypoxia, which means that the PaO2 is less than 8 kilopascals, so 60 millimeters mercury, with a normal or low PaCO2. And this generally is due to a ventilation perfusion mismatch or VQ mismatch, commonly due to a primary lung pathology. So the common causes for type 1 respiratory failure are common lung problems like pneumonia, pulmonary aspiration, pulmonary edema, ARDS, fibrosing alveolitis, COPD, emphysema, lung contusion, lung trauma, and even pulmonary surgery. So what is type 2 respiratory failure? So in type 2 respiratory failure, there is a hypoventilation with or without a ventilation perfusion mismatch. So the causes leading to type 2 respiratory failure could be a defect anywhere in the respiratory pump. What I meant by the respiratory pump was from the place where respiration is initiated, the respiratory center in the brain, down to the lungs and up to the airway. So causes for type 2 respiratory failure can be worked out by looking at the important organs and places that are involved in the respiratory mechanism. For instance, we can start with the brain. So what are the central causes for a respiratory failure type 2? Causes like head injury, meningitis, encephalitis, any other infection or inflammation of the brain, especially involving the respiratory center. Effects of drugs like sedatives, benzodiazepines, anesthetics and opioids, and any other central nervous system trauma. These are the common causes. Then going down from the brain to the spinal cord, any lesion involving the cervical spinal cord like cervical spinal trauma can lead to a type 2 respiratory failure. Going further down, any problem even in the thoracic spine can also lead to a respiratory failure. Then looking at the anterior horn cells of the spinal cord, any lesion in the anterior horn cells like poliomyelitis or motor neuron disease can lead to a type 2 respiratory failure. Then going further away from the central nervous system, when you look at the peripheral nervous system, any nerve involvement of the nerves that are dealing with respiration can lead to respiratory failure. The common ICU condition which all of you will remember is Guillain-Barré syndrome. Going to the more peripheral parts of the respiratory mechanism, now if we look at the neuromuscular junction, where the nerves that are dealing with breathing meet the respiratory muscles, causes like snake venoms, OP poisoning, myasthenia gravis, and Eaton-Lambert syndrome can cause respiratory failure. Then going to the peripheral parts of the respiratory mechanism further, primary problems of breathing muscles can lead to respiratory failure. Any cause that can lead to a diaphragmatic problem like a trauma to the diaphragm, surgery in the diaphragm can lead to respiratory failure. Then muscular dystrophies and myopathies can lead to respiratory failure. Now you move in further where the respiratory muscles are now in contact with the inner parts of the inner respiratory tract. So any problem leading to disease in the lungs, again like a pneumonia, pulmonary aspiration, pulmonary edema, again can cause type 2 respiratory failure. Going in further, issues arising in the airway, in the lower airway, lower respiratory tract, or the middle part of the respiratory tract, or the upper part of the respiratory tract, ranging from bronchospasm to airway obstruction, can lead to type 2 respiratory failure. In addition, any problem in the chest wall which can obstruct, which can disturb the breathing mechanism, can also cause type 2 respiratory failure. So things like pneumothorax, hemothorax, chylothorax, hemopneumothorax, tension pneumothorax, or trauma to the chest wall leading even to severe contusion, which will prevent the patient from breathing due to severe pain. All these can finally lead to type 2 respiratory failure. So what are the clinical features of respiratory failure? How will a patient present with respiratory failure? So generally a patient presents with signs and symptoms related to the underlying cause for respiratory failure, with in addition signs and symptoms due to hypoxia plus or minus hypercarbia. So a patient with in hypoxia generally presents with severe respiratory distress, with finding it difficult to breathe, respiratory distress, dyspnea, shortness of breath, and there will be even cyanosis. Patient will be struggling, agitated, confused. Occasionally the patient can be very violent even. And a patient who is chronically hypoxic can have even polycythemia. So a hypercapnic patient, a patient with hypercarbia, generally complains of a headache. There will be peripheral vasodilatation, tachycardia, bounding pulse, even papilledema. Patient may be drowsy, may even become comatose. Now let's see what are the investigations that we are going to do on a patient with respiratory failure. So once a patient has presented with respiratory failure, you start treatment first, and investigations would be done while treatment is going on. So basic investigations like looking for a cause for the respiratory failure has to be done. So see whether there's infection or inflammation going on. So inflammatory markers have to be done, like a full blood count with full white cell count and a blood picture, and C-reactive proteins and procalcitonins under inflammatory markers. Then do an arterial blood gas analysis immediately, and need to do baseline investigations like serum creatinine, blood urea, serum electrolytes, and basic liver functions. Then obviously the patient is going to need a chest x-ray, so better to do an inward chest x-ray on wherever the patient is, and then need to do some microbiology investigations to see whether the patient is having infection, systemic infection or respiratory tract infection. So try to get a blood culture and a sputum culture. Well, if the patient is intubated, then we can take a tracheal aspirate sample for microbiology. Then spirometry is another bedside test that you can do. It will especially be useful in patients with COPD, copulmonale, and patients like in Guillain-Barré. Right, so how do you manage a patient with respiratory failure? So management again depends on the underlying cause. So you have to address the cause, and at the same time you have to try and correct hypoxia, try and correct hypercapnia. And meanwhile you have to do supporting the vital parameters like supporting blood pressure, respiration and level of consciousness. So all these three things have to happen simultaneously. So addressing the primary cause, the cause behind respiratory failure, addressing hypoxia and hypercapnia, and stabilizing vital parameters. So unless the blood pressure is very low, we generally should prop the patient up at least 45 degrees to 60 degrees. That will make the patient feel comfortable and will ease the difficulty the patient is having. So put the patient on oxygen through a Venturi mask. So you can start with, for type 1 respiratory failure, you can start with 35 to 60% oxygen to start with. Can do a repeat blood gas after 15 to 20 minutes and then see where the patient is, and depending on whether the patient is still hypoxic, you can go up on FiO2 or the inspired fraction of oxygen. If it is enough, you can stay there or even come down on the amount of oxygen that you are giving. And if it is type 2 respiratory failure, some of the patients who present with type 2 respiratory failure, their respiratory centers may be insensitive or less sensitive to hypercapnia, and they may be dependent on a hypoxic drive for breathing. So in a situation like that, if you put the patient on a very high inspired fraction of oxygen, then patient's breathing might get jeopardized further. So you have to be very careful in a tricky situation like that. So you have to start the patient on a lower percentage of oxygen, like 24% oxygen in a patient who is having a chronic obstructive disease like patient, and see where the patient is after a repeat blood gas, which is done in about 15 to 20 minutes, and then increase the FiO2 if necessary. Meanwhile, we have to, so while addressing the hypoxia and hypercarbia, we have to keep looking for a cause for the respiratory failure. So if the patient is continuously hypoxic or hypercarbic, patient has to be started on ventilation. So initially you may start the patient on non-invasive ventilation, like starting on a non-invasive CPAP, and if it is inadequate, you will have to intubate the patient and start invasive ventilation. Meanwhile, if the patient's blood pressure is low, you have to support the blood pressure. So anyway, in a patient with respiratory failure, soon after propping up the patient and putting on oxygen, and you will have to open an IV line with an IV cannula, start a running drip. You have to be careful about the drip rate. You don't have to give a lot of fluids very fast. You have to primarily you have to keep the IV access open. So meanwhile, if the patient has developed arrhythmias due to hypoxia or hypercarbia, you might have to break that by giving an antiarrhythmic agent. If the patient develops a bradycardia, you have to give some atropine. And meanwhile, if the patient's blood pressure is very low, you will have to start the patient on an inotrope. And if the patient is septic, vasoconstrictor like noradrenaline would be better. And meanwhile, if the patient is looking like very septic due to a low respiratory infection, or a patient who has presented with infective exacerbation of chronic obstructive pulmonary disease or asthma, you might have to start him on empirical intravenous antibiotics. Sometimes in a patient like an asthmatic or COPD patient, you might have to start the patient on immediate nebulization of beta-2 agonists like salbutamol or even ipratropium. And sometimes back-to-back nebulization is essential. You nebulize once with salbutamol 5 milligrams, which is 1 milliliter, and distilled water 1 milliliter, and the patient is not relieved. You may repeat it in 5 minutes, and if it doesn't work, you may repeat nebulization in another 15 minutes time. And so even back-to-back nebulization, repeated nebulization, if those do not improve the blood gases, and if those do not improve the patient's clinical picture, and if the patient is continuously hypoxic or hypercarbic, now we will have to intubate the patient or start the patient on non-invasive ventilation. So something we have to keep in our minds is we have to set up monitoring, ECG monitoring. So look at the ECG. Patients can throw various arrhythmias due to hypoxia or hypercarbia, There can be various underlying cardiac pathologies that are seen in the ECG. So start 5-lead ECG monitoring, set up pulse oximetry, and try to see what end-tidal capnography is. You can measure that even when the patient is breathing on a ordinary face mask, or even when the patient is on non-invasive ventilation. You can easily do it if the patient is intubated. You have to check the blood pressure very frequently, at least every 5 minutes. And if the patient is very sick and intubated, then that is the time you have to go for a intra-arterial line and a central venous line. And after intubation and after finishing the initial work, you have to get a chest X-ray to confirm the position of the endotracheal tube. Right. Now let's see. Let's assume that you have done all the preliminary work that you have to do on a patient on respiratory failure. You have put the patient on oxygen, done nebulization, opened IV access, taken blood and other specimens for basic investigations, done the chest X-ray and given initial drugs, but the patient did not improve. Therefore, you have intubated the patient, and now you have taken the patient to the intensive care unit and connected to the ventilator. Now let's see what's happening in the ICU with an ICU ventilator.
Okay, now we have intubated the patient. Now we are going to connect the patient to the mechanical ventilator. So this is the mechanical ventilator now we are going to use. There are several modes that we can use. To select the mode, we go to the menu and it has the ventilatory modes there. I'm going to select ventilatory modes and it shows up all the ventilatory modes that are available in the ventilator. Today I'm going to select the SIMV volume control method. So I would select SIMV volume control method and then I'm going to OK it. So we are now going to select several parameters in the ventilator. I'm starting from the FiO2. That is the fraction of oxygen that we are going to deliver to the patient, which I'm going to select 60 here. Then we have to select the respiratory rate, that is the number of ventilatory breaths that we are going to select here. I'm going to select 10 here. Then we are going to select the IE ratio. The usual IE ratio we start with is 1 to 2, that is the natural IE ratio. Then we are going to select the tidal volume. So I'm going to put 420 here. The pressure limit is the maximum pressure that the ventilator should reach. I am going to keep it as 30. And then PEEP, again it is the positive end expiratory pressure. I am happy with PEEP of 5 for this patient. And then the pressure support, that is the support that we give for the spontaneous breaths of the patient, for which I am going to select 10 here. And this is the trigger, inspiratory trigger, which I am going to keep at 2 liters per minute. Now we have set the main parameters of the ventilator. Now in this side we can see what is actually happening in the patient. The minute ventilation of the patient now is 4.5 liters, which is adequate for this patient. And the tidal volume delivered to the patient is 420, and there is no discrepancy with the tidal volume we have set and the delivered tidal volume. So there is no leak in the ventilator. The peak pressure that the patient is achieving is 22, which is quite normal. And the minimal pressure is 5, that is actually the PEEP that we have set. And here the patient is getting about 76% of oxygen, and this is because there is some equilibrium time. It will reach 60 after a little time. And then the respiratory rate, total respiratory rate is 10. The patient is not spontaneously breathing yet. There are no additional spontaneous breathing yet. The set rate is the respiratory rate of the patient now. So we are happy with setting up the ventilator, and we can keep this ventilatory setting for about half an hour's time, and then we can do a blood gas analysis and decide on the adequacy of ventilation. this is a ventilatory graph. It shows the airway pressure changes with time. And the line that is indicated in blue are patient's spontaneous inspiratory breaths. But it is supported by the mechanical ventilator, and the peak airway pressure that it reaches is roughly around 20. And there is a little plateau, and then the pressures drop to the PEEP, that is the end expiratory pressure. And you can see intermittently there are tiny breaths appearing. You'll see. So this is a tiny breath, that is a spontaneous breath which is not supported by the mandatory breath, but it is given a pressure support of 10 as we have said, and it is reaching an airway pressure of about 50. And this graph totally shows how the pressure changes with time. Once we have intubated and set up the ventilator, we have to make sure that the patient is doing all right. So this patient has a heart rate of 67, which is quite okay, and the blood pressure is 146 by 88. He is hemodynamically stable, and she has a saturation of 99, which is good. However, the ETCO2 is 28, which is quite little lower than the normal ETCO2 value. So we are over-ventilating this patient. We will do the arterial blood gas analysis as well and see whether this is correct. And if that is so, if the carbon dioxide is low, we are going to reduce the minute ventilation of the patient by either reducing the respiratory rate or the tidal volume. Now we have done a blood gas analysis. This is an arterial blood gas analysis. We can see a pH of 7.54. So patient is little bit alkalotic. What is the reason? The carbon dioxide is 26. On the ETCO2 also we saw a carbon dioxide of 28. So it seems they are tallying. Carbon dioxide has dropped than the normal level. The oxygenation is 123, which is quite okay, and this is with the FiO2 of 35%, so her lungs are doing quite well. So we have to get the carbon dioxide increased, and it will correct the pH as well. So we can either reduce the respiratory rate or the tidal volume. The tidal volume can be reduced by reducing the tidal volume we set in the mechanical ventilator, or by reducing the pressure support that we are giving to the patient, and thereby we can reduce the minute ventilation, so the carbon dioxide will gradually start to rise and the pH will be corrected. So here now I am going to reduce the tidal volume to 350, and also I am going to reduce the respiratory rate to 8. At the same time, I am going to change the IE ratio as well. Without settings, the IE ratio has changed. Now we can see the minute ventilation was initially 5.2. Now it is coming down to 4.9. Here we are now expecting a rise of ETCO2.